And then you masuk hematology, and then suddenly macam, wait, the neoplasms are not even called OMA, right? The cancers are not even called OMA. Why? Because blood is not a solid organ, right? So there is an OMA in hematology when it involves the lymph nodes, because the lymph nodes is a solid organ, right? But when we're talking about the blood is not a solid organ. So the term that we use is leukemia, right? Why we use the term leukemia? So the word leuke denotes white cells. Emia denotes blood. So whatever's in the blood. So similarly, like anemia, we're talking about not enough blood, right? So leukemia is white cells in the blood. Okay, so it's just a mind shift for a bit, but it's something that you do have to wrap your brain around lah. So that is why in Prof. Rida's lecture, we talk about leukemia, and we talk about whether it's an acute type of leukemia or a chronic type of leukemia. So the main differences between acute leukemia and chronic leukemia is that acute is very aggressive. Okay, so it happens very quickly. It's it causes harm in a shorter space of time because it proliferates very fast. Okay, so that's why it's acute. So anything acute denotes something happening quickly and something happening severely. Okay, whereas chronic denotes something that is more slow growing or more it occurs over a longer period of time. Okay, so going back to Dr. Rida's lecture, she gives you the different types of acute leukemias and the different types of chronic leukemias, correct? Okay. Now, what is myeloproliferative neoplasms then? So, because I've used the word neoplasm here, right? So, where does this all fit? Okay. So, myeloproliferative neoplasms, like the term suggests, so myelo refers to white blood cells of the myeloid origin. Do you know what cells are of the myeloid origin? What cells? Sorry? Neutrophils? Absolutely.
Eosinophil.
Eosinophil. Basophil.
Apa lagi? Neutrophils.
Eosinophil.
Okay, wait. What white cells do you know? What types of leukocytes do you know?
Neutrophils.
Basophils,
Basophils. Eosinophils.
eosinophils,
Macrophage.
macrophage, okay. Although macrophage is a cell, a white cell that is not in the blood, it's in the tissue. So what is a macrophage equivalent in the blood?
Monocyte.
Monocytes, lagi? What other white blood cells do you know besides those four? Lymphocytes, B and T lymphocytes, right? So those are the general groups of cells, right? So lymphocytes, lymphocytes, as the name suggests, are lymphoid cells. Okay, they are of lymphoid origin, whereas all the four other cells that you mentioned just now, they are of the myeloid origin. Okay, and what does that mean? It means it shares the same stem cell. So dia punya cell yang paling primitive, the most primitive cell, gives rise to all these different types of cells. Okay, now not only does it give rise to your white cells, but funnily enough, it can also give rise to your red cells and your megakaryocytes, your platelets, the cells that make the platelets. Okay, so macam first, I'm not sure whether you're familiar with this diagram, but there's one stem cell, and then it decides I want to be of myeloid origin, it becomes like a myeloid progenitor, or it becomes a lymphoid progenitor. From the myeloid progenitor, it can become a neutrophil or monocyte or erythroid depending on what the need is lah. But they originate from the same primitive cell. Okay? So what happens is this cell then decides to become whatever it wants to become. Okay, dia nak jadi doctor ke, dia nak jadi lawyer ke, right? But it decides that so something happens, right? It, like all neoplasm, something happens, and the adult cell proliferates. Okay. Okay, so that's the general big picture lah. So I'll try and further explain as we go along, but I hope I haven't lost you. Okay, are we clear so far?
Yes.
Okay, so again, learning outcomes, best friends, right? It should be something that you look at constantly. So the learning outcomes for this lecture is you should be able to define the different types of myeloproliferative diseases or neoplasms and discuss the classification. And then there's a term that I will introduce today called polycythemia. Have you heard of this term before? Has it been introduced before? Okay, so you should have been introduced in your year 1, year 2. So we're going to talk about what's the difference between absolute and relative polycythemia and primary and secondary polycythemia. What's the difference? And then we're going to talk about each myeloproliferative neoplasm, MPD or MPN, and discuss in a bit more detail what are the differences, what are the clinical features, how do we investigate, how do we diagnose, how do we treat. Okay? Okay. So I hope you all are aware that all our blood cells are made in the bone marrow, right? So what enters the circulation is cells that are ready to work. Okay? So they're mature cells. They are cells yang dah graduate. Dia dah jadi doktor, dia dah jadi lawyer, lepas tu baru dia masuk the real world. Okay? Before that, they stay in the bone marrow. Right? So bone marrow is where the action's at. So the bone marrow will have all the cells that are meant to become something. It will have your megakaryocytes that will become platelets. It will have nucleated red blood cells. Okay, because I hope you know by now that in our circulation you don't have nucleated red cells. All the red cells that circulate are anucleated. Okay, we don't want cells with nucleus, red cells with nucleus in the circulation. Okay, because it reduces the function. And then you have cells that eventually become your white cells. Okay. Just to note that I'm not sure whether this will further confuse you, but lymphoid cells, right? While they originate in the bone marrow, right? They don't mature in the bone marrow. Okay. They come from the bone marrow, but before they're ready to go into the circulation, they have to go to another school first. Okay, they have to go to they have to go for postgraduate studies. They kena pergi lymphoid tissue dulu. Okay, so they have to go to the lymph nodes to become functioning cells. Okay, when they leave the bone marrow, they are mature cells, right? But they're still naive. Okay, dia macam macam ni lah. Dia macam before you all nak jadi doktor, you kena buat housemanship dulu. Mesti lah. You pergi lymph node, buat housemanship dulu, itu baru boleh keluar. Dia doktor yang betul. Kalau tidak, tak jadilah. Okay? So, now this is a concept that you have to understand because then it makes it easier for you to understand how come there are a myeloproliferative neoplasm and there's no lymphoproliferative neoplasm in the bone marrow per se. Okay? So, myeloproliferative neoplasm basically means an overproduction, like I said just now, an overproduction of these mature elements, of your red cells, of your platelets and of your white cells, the mature ones. Okay? But the point of origin is still the stem cells. Okay? So what happens is the stem cells proliferate, but these cells are able to mature. Okay, so they make it in abundance, and these cells, because at the end of the day, dia punya origin pun memang stem cells kan, kan? So what proliferates, okay, is basically how do I put this? So the stem cells proliferate, but at the same time, it is able to make mature cells. So the cells that they create are able to mature. Unlike acute leukemia, the cells that they create, that proliferate, have a maturation arrest. It doesn't go past becoming mature. They are not able to mature. So it keeps making primitive blasts. It keeps making blasts. Whereas in a chronic leukemia, the stem cells are the cells that proliferate, but the cells that they create are able to become mature. So they become a proliferation of the mature cells. Okay? So the diagram on the right shows that, right? So I said that the hemopoietic stem cell is the most primitive one, and that can become either a myeloid progenitor or a lymphoid progenitor. And when it becomes a myeloid progenitor and it decides to be any one of those cells, then the corresponding myeloproliferative neoplasm is in the column in the middle. Okay? So under the umbrella myeloproliferative neoplasms, you have essential thrombocythemia, you have polycythemia vera, you have chronic myeloid leukemia, and you have primary myelofibrosis. Now, I'm not touching on chronic myeloid leukemia because I'm assuming that Prof. Reda has mentioned it, right? But I want to draw parallels with chronic myeloid leukemia to reiterate the fact that this is a proliferation of mature cells. Okay? So just like in chronic myeloid leukemia, because the cells that they create are the mature type, walaupun in abundance, in very, very vast amounts, they are still mature cells. So in a way, they are still kind of functioning. Okay? I mean, they're not perfect because they are tumor cells, but they can still kind of work. Okay, so that's why putting all those things together, that's why their presentation is a lot more chronic. Okay, because it's not like in acute leukemia where all the cells that they make are just blasts, and in the bone marrow, because the factory is just so full of blasts, it's not even able to make normal cells, and therefore, you are walking around with just a high number of blasts and not your normal cells. Of course, you're going to go into trouble lah. You're going to have anemia. You're going to have thrombocytopenia, right? You're not going to be able to stop bleeding. You're not going to be able to fight infection because all you have are useless blasts, primitive cells, right? But in chronic myeloid leukemia or in chronic lymphocytic leukemia, these cells bolehlah function sikit-sikit. Okay? So it's not as acute as your acute leukemias. And then you have the smaller print ones, which I don't expect you to know at this level, which is chronic eosinophilic leukemia, chronic neutrophilic leukemia, and systemic mastocytosis. Okay, so these are the ones that you're not expected to know because they're not that common. Okay, so drawing parallels with the neoplasm lecture that Prof. gave, there's the term tumorigenesis, right? How does the tumor occur? Something has to happen for the tumor to occur. Something has to happen for the neoplasm to occur. And we've talked about the upregulation of what's the word? What's this cage? Or, okay, so the opposite of tumor suppressor genes is called what again?
Oncogene.
So my brain is okay. So you know that if you upregulate oncogenes, then that can lead to cancer. If you suppress tumor suppressor genes, then that can also lead to cancer, right? So in myeloproliferative neoplasm, it's the mutation of a tyrosine kinase gene, which is an oncogene. Okay, it's a gene that that enhances proliferation of the cells. Okay, so where else have you heard the term tyrosine kinase gene? You should have learnt it last week. Tyrosine kinase. And you should have heard it in Iron's lecture as well. She would have mentioned it. Tyrosine kinase. No? Doesn't ring a bell? BCR-ABL? Does that ring a bell?
Oh,
What's BCR-ABL?
gene. Yang
What's
hasilkan.
BCR-ABL? Sorry, I tak ada hadiah. Dr. Haris sudah bagi hadiah kan? Tak ada hadiah nak bagi. Hadiah I doa, you also pass.
Oh,
Come on, BCR-ABL gene. You should have learned it last week. Or Monday. Was it Monday?
bun biru yang buat
Yes.
vaksin.
Lecture was Monday.
She said that aku kena atas orang. Kita cinta
Come on. I'm sure one of you knows the answer to this. BCR-ABL.
or konitnya. Memiliki
I'm drawing some really blank stares.
Leukemia?
Huh?
Leukemia?
Yeah.
Chronic myeloid leukemia.
Okay, chronic myeloid leukemia. Right. So what is it a product of? What sort of mutation is it? Translocation of what chromosome? 922. Okay, so BCR meets ABL and becomes a supergene, right? So the product of the BCR-ABL gene produces a tyrosine kinase. Do you know that? Do you know that in CML, the mainstay of treatment is a tyrosine kinase inhibitor, right? Okay, tahu tak? Okay. So CML is actually like one of the biggest success stories. So dia macam famous sangat. Okay, because it's one of the first neoplasms where they found that the pathogenesis was this translocation 922. And the fact that these two genes make a fusion gene to produce a fusion protein from the BCR-ABL protein. And this protein basically drives the proliferation. And then chemists, pharmaceutical companies found a way to stop this protein from working by producing a tyrosine kinase inhibitor. It's like one of the biggest success stories in medicine, not just in hematology, but in medicine, so it's very famous. Okay, so similarly with that, in myeloproliferative neoplasms, it's also a mutation of the tyrosine kinase gene. Okay, so it enhances proliferation, but instead of the BCR-ABL gene, okay, the genes that are known to cause myeloproliferative neoplasms are called JAK2. There's two other mutations, but they're not as popular, or because they're not as common as JAK2. Okay, called MPL and CALR, right? They're not as popular because they're not as common as JAK2, but they are also have tyrosine kinase activity. Okay, but if you don't remember anything else from this lecture, just remember that JAK2 is also a tyrosine kinase inhibitor. Okay, and it's the main mutation or main gene that is affected in MPN that drives the proliferation of cells. Okay, so mutation of JAK2 occurs in 95% of polycythemia vera. it occurs in about 50% of essential thrombocythemia and about 50 to 60% in myelofibrosis. Okay? So that's how common it is. Okay. So that's just a picture to okay. So I digress a little bit and let's talk about polycythemia because one of the myeloproliferative neoplasms is called polycythemia vera. What does the term polycythemia mean?
A lot of
Proliferation
a lot of cells in the blood.
the blood.
It's not the lecture again. So it basically means increased red cell mass, right? So poly means banyak, psi is usually to denote cells, and emia means blood. So banyak cells darah, right? So polycythemia just means a lot of red blood cells. But you can get polycythemia because you have a lot of red cells, or you can get polycythemia because you have the same number of red cells, but the plasma volume is reduced, right? Because the concentration is always the solute per the solvent. Look, okay? So the solute here is your red cells, and your solvent is your plasma. Okay? If you put a lot more solute in the same amount of plasma in the solvent, of course you're going to have a higher concentration. Betul? But similarly, if you have the same amount of solute but you lessen the solvent, again, that increases the concentration, right? Okay. So if you have an increase in the red cell mass, that's an absolute polycythemia. But if you have a polycythemia with less than plasma with a plasma volume less than usual, then that's a relative polycythemia. Follow?
Yeah.
Right? So in what situations can you get relative polycythemia then?
Dehydration.
Dehydration? Yep. Lagi?
Shock.
Burns, right? Because you lose a lot of fluid because your skin is burnt off and you expose your dermis and you lose a lot more fluid through evaporation. Okay? So similar to dehydration. Okay? But why isn't hemorrhage a relative polycythemia?
Because we lose red blood cells.
Because you lose both. You're losing your plasma and you're losing your red cells. Okay? So polycythemia denotes how much of red cells. So it's more of a quantity thing, right? It's a concentration. Okay, so then you can have different causes for absolute polycythemia, right? So in absolute polycythemia, you can categorize it as primary and secondary. So primary usually means that the problem originates from the origin. Okay? Primary means that macam memang the problem is with the organ lah. Okay? Whereas secondary means that it's happening because something else is affecting it. Right? It's driven by an external factor. Okay? So in primary polycythemia, there's satu je, polycythemia vera, that I expect you to know at this level. And then in secondary, you would have other causes. So as you would imagine, a patient who is exposed to chronic hypoxia would have a polycythemia. Why? Kenapa?
To increase oxygen
Right.
transportation.
So to increase the oxygen delivery to the tissues, because the body keeps saying to the bone marrow, tak cukup lah oxygen. Okay, so what do I do? Kalau tak cukup oxygen, how can I help? Yeah,
Increase
I
red
increase
cell.
more red cells, right? So which is why in cyanotic heart diseases, cyanotic congenital heart diseases, babies can get polycythemia because they are constantly hypoxic. So the bone marrow says, okay, let's produce more to help this baby live, right? So chronic hypoxia is one of the main causes of secondary polycythemia. And then So whatever causes chronic hypoxia lah. So high altitude, chronic smoking, they can all lead to chronic hypoxia. Okay, and then you can have neoplasms that produce erythropoietin. So what's erythropoietin? It's a hormone for erythropoiesis. Where is it produced? In the kidneys. Okay, so if you have a tumor that produces erythropoietin, then that will also lead to polycythemia. Okay, and then we talked about rheumatoid polycythemia already. Okay, so let's focus on polycythemia vera. So the term is kind of misleading because it denotes macam as if the red cells je yang proliferate. Okay, the red cells je yang banyak, the red cell mass je yang increased. But actually, if we look at the bone marrow, if we look at the factory, all 3 cell lines are increased. Okay, but it's more pronounced, it's more obvious in the red cells. So that's why when it was first described, they used the term polycythemia vera. Okay, but in actual fact, it's a proliferation of 3 cell lines. Okay, and that said, the polycythemia is the one that gives the most problem. The increase in the red cell mass is what causes the patient to have symptoms. Okay. So again, the pathogenesis is a mutation in the JAK2 gene, okay, and it occurs in exon 12, okay, at the position of 617, valine V is replaced by F, and this mutation, it's a point mutation, right, that leads to a constitutive activation of JAK2. What does that mean? Basically, it always makes the gene switched on. The gene is always switched on, it's always activated. Dia tak boleh nak switch off. Okay, sepatutnya oncogenes are switched on at appropriate times and switched off when it's not needed anymore. But here, it's constantly on. Okay, so like I said, the polycythemia is what's the most problematic. So the clinical features, you will have hyperviscosity syndrome. So hyperviscosity syndrome just basically means your blood is very thick, and of course that's because you have increased red cell mass. Okay, so in hyperviscosity syndrome, patient will appear plethoric. Plethoric is when they appear very red, very congested. They'll have splenomegaly, and they'll have dysfunction in hemostasis, bleeding, and thrombosis. Okay. So the diagnostic criteria for polycythemia vera. How do we diagnose it? So we have to take a few things into consideration, right? So like I said, with any diseases, usually there's a criteria to diagnose. Okay? We can't just say it has one thing and therefore terus patient tu macam tu. Like we have to put the clinical symptoms together, all the investigations together, and if it fits the criteria, then we can safely say that this patient has that disease. Okay, so similarly with PV, the diagnostic criteria is that, so first and foremost, it has to have an elevated hemoglobin concentration. Okay, so either the hemoglobin is increased, or you look at the hematocrit, which is the marker for polycythemia, right? And then, because we know that you can have secondary polycythemia, you can have secondary causes, we look at the bone marrow. Why? Because in these myeloproliferative neoplasms, they will have certain features in the bone marrow that is different from if it was a secondary polycythemia. Okay? The features in the bone marrow helps us to further diagnose lah, because if it fits the typical picture that's always been described in the books, then we are more inclined to believe that this is polycythemia vera rather than secondary polycythemia. So what are the features in bone marrow? Nanti I tunjuk. And then of course, because it's a mutation of the gene, so we look for the presence of the JAK2 mutation. Okay, so those are the 3 major criteria. Now, another minor criteria is subnormal serum erythropoietin level. So what does that mean? What does subnormal serum erythropoietin mean? Okay, so subnormal means it's below normal. So why do patients have a below normal erythropoietin level?
Kidney tak mancing.
Because of what's the term? So erythropoietin is a hormone, right? We discussed that already. So what happens with hormones? How is it regulated?
Negative feedback.
Negative feedback, right? So when you have a lot of red cells, right, the feedback to the kidneys will be stop making erythropoietin, right? That's only natural sebab the kidneys dah macam banyak sangat ni red cells, dah cukup, don't make anymore. So by reducing the erythropoietin level, the body thinks that okay lah, I can reduce the number of red cells, but of course that doesn't happen lah because the mutation, the drive is genetic. Okay, so in polycythemia vera, like I said, there is a proliferation of all three cell lines. So instead of just seeing a proliferation of erythroid cells, you will see pan-myelosis. So pan means it covers everything. Myelosis means proliferation of myeloid cells. So you'll have an increase in erythroid cells, you will have an increase in megakaryocytes, and you'll have an increase in granulocytes. Okay, so it's pan-myelosis. So these are megakaryocytes, yang besar-besar ni. Okay, and these two here as well. That's a megakaryocyte there. So megakaryocytes are large and they are multi-nucleated. Okay, so characteristically, they have more than 2 nucleus. Okay, usually they have 4 or more. If they have less than that, it's a feature of a dysplastic megakaryocyte. Okay, and usually they are large. If they are small, it's also another feature of dysplasia. And the nucleus of the megakaryocytes, they tend to clump together. Okay, they stick together lah. If they are separated from each other within the cytoplasm of the megakaryocyte, that is also another feature of dysplasia. Okay, so these are the clues as to whether or not these cells are abnormal or normal. Okay, so here morphologically they look rather normal. Okay, they're large, they're mature looking, they have lots of nucleus, and the nucleus sticks together. Okay, so that's why I say in myeloproliferative neoplasm dia macam the cells tu macam okay lah, not normal, but they're not that abnormal. So the features, the clinical features is not so severe. Okay, because you can have a proliferation of dysplastic megakaryocytes. Okay, and and therefore when they are so dysplastic, the product that it produces is completely useless. Okay, but here in polycythemia vera, they look quite normal. It's just that in quantity, there are a lot. Banyak. There's a lot of these megakaryocytes. So similarly with the other cell lines, there's a lot of erythroid cells, and there's a lot of granulocytes. Okay, granulocytes is the term that we use to describe the neutrophil cell line. Daripada promyelocyte sampai ke neutrophils. Okay, so that's just the umbrella term, granulocytes. Okay, because they have granules. Okay, so how do we treat it? So the aim is to actually reduce the red cell number. The aim is to maintain the blood cell count. So we can actually venesect. Venesect means just to keluarkan darah lah. Macam derma darah macam tu. So we take out the patient's blood. So sometimes we take out about 500 mils. Sometimes pernah I take out 1 liter of blood for patient because the number of the hematocrit level was so high. Because if your hematocrit level is very, very high, it becomes very viscous and it can cause stroke, right? Because it's really thick, right? So blood doesn't flow very well. It can cause, if patient has underlying heart disease, it can cause an MI, right? Because the blood is so thick. So we try to remove it quickly by removing the blood. So it's used to reduce counts rapidly. And then you can have medication that controls the counts, that reduces the counts. And usually these medications, the mechanism of action targets proliferation. So it will be it will be drugs that affects the cell cycle, stops the cells from proliferating. Okay? Okay, so that's PV. Any questions? So I didn't dwell on the clinical features, but I want you to go back and read and try to make sense of it. So hyperviscosity syndrome, patients can have a lot of complications from that. So I want you to go back and have a read, okay? Now the second one is essential thrombocythemia. And what this is basically is a proliferation of your megakaryocytes, okay? So as a result, what we see in a full blood count would be a raised platelet count or thrombocytosis. Okay, but here, not sure why, but instead of thrombocytosis, which is the term that we normally use for raised platelets, the person who named this disease decided to use the term thrombocythemia instead. But it essentially means the same thing, right? Because thrombocytes is basically the other name for platelets, right? And emia is blood. So platelets in the blood, right? So raised platelets. So it's a marked proliferation of the megakaryocytes leading to thrombocytosis in the peripheral blood. And the upper normal of platelet count, usually in adult, is 450. Okay, so higher than 450 is thrombocytosis. So if you have a sustained thrombocytosis of more than 3 months, usually that is what we define as a persisting raised platelet count. Okay. So again, JAK2 is implicated, but like I said, there are other genes that can cause essential thrombocythemia. So as you can imagine, of course, if there's lots of platelets, thrombosis will occur very easily. Okay. Now, when thrombosis occurs easily, that tends to drive even more thrombosis and drives the consumption of platelets. Okay, and like I said, while the platelets can work, it may not work that well, so it can also lead to hemorrhage. So in some patients, they come with thrombosis. In some patients, they come with hemorrhage. Okay, and most of the cases are actually symptomless. A lot of the times, the cases that comes to me are patients they are found incidentally to have high platelet count. What does incidentally mean? It means that they're not ada symptoms pun, but actually they pergi buat full blood count for another reason. Tengok-tengok they have a raised platelet count. Okay, a lot of the times it's like they do a routine check or they want to go for Hajj and they have to do a full blood count. Dan tiba-tiba ada raised platelet count. Macam itulah. So macam dia tak ada symptoms pun. So it's an incidental finding. Okay. So what is the major criteria? You have to have a sustained platelet count of more than 450. And then you have to have the bone marrow. And then you have to have the presence of the mutation. So dia sama dengan a PV. The difference is instead of a raised hematocrit, now it's just a raised platelet. Okay? And then the minor criteria here is presence of a clonal marker. So what does that mean? Clonal just means that it's proliferating, the same abnormal cell is proliferating. So that's a clonal marker. So it can be anything. It can be like an abnormal karyotype. It can be the presence of another mutation. Okay, so if there is a presence of a clonal marker, it's also considered a minor criteria. Okay, and of course they have to rule out reactive thrombocytosis, because you can have a lot of cases of secondary thrombocytosis. Okay, one of it is IDA. So iron deficiency anemia is well known to cause a reactive thrombocytosis. Okay, so what do you see in the full blood picture? Tadi for PV I didn't show you because I don't really think you'll be able to appreciate it. Tapi hopefully next week when I do the practical, I can show you a bit more cases lah. So in the full blood picture of a patient with essential thrombocythemia is that they have a lot of platelets basically, and the platelets, instead of being sort of like one size, they can vary in size, besar, kecil, okay? And sometimes you might even get a megakaryocytic fragment in the circulation. So as you can imagine, sepatutnya a megakaryocyte fragment shouldn't be in circulation. What should go into the circulation is just little buds of megakaryocyte cytoplasm. Okay? So megakaryocytes are huge and it can bud off and make platelets. But sometimes in ET, you see a huge fragment of the megakaryocytes in the blood. So this is the normal size of a platelet usually. Okay? And these are the larger and giant types. So in the bone marrow, what do we see? We see just a proliferation of abnormal abnormal megakaryocytes. Why I call them abnormal is because there's a lot of it. Okay, clusters together. Usually, megakaryocytes, if you look at a normal bone marrow, it's like one, a stone's throw away. Like you see one over there, one another place. So dia jarak-jarak lah. It's not clustered together. But in essential thrombocythemia, they cluster together, and they're very large, very larger than usual megakaryocytes. Okay, but they're mature megakaryocytes, so they can still make platelets. Okay, so again, the treatment, the aim is to reduce thrombotic or hemorrhagic events. So how do you reduce the risk of thrombosis? We give aspirin. Okay. Have you done this in pharmacology?
Yeah.
Aspirin, right? So aspirin reduces the risk of thrombus formation. And to reduce the number of platelet counts, again, it has to deal with cell cycle. So anything affecting the cell proliferation will stop the cells from proliferating and therefore reduce the number of platelets. Okay, so this is the last one, primary myelofibrosis. And this is kind of a weird one. Why I say weird? It's because the proliferation is of your myeloid cells, right? Or more importantly, maybe megakaryocytes. But the resulting disease actually causes a reduction in the counts. Okay? So tadi Dr. Lan cakap macam in myeloproliferative neoplasms, the cells are increased, the cells are increased. And suddenly macam pancytopenia pula, right? So this is a weird one because while the neoplasm actually drives a proliferation of the megakaryocytes, the megakaryocytes induces fibrosis of the bone marrow. So ultimately, while in the early stages you can have a high white cell count and a high platelet count, but subsequently, once the fibrosis sets in, your factory will not work anymore. And therefore, you will get a cytopenia rather than a cytosis. Okay? So it's again a clonal myeloproliferative neoplasm, and it's predominantly of the granulocytic and megakaryocytic lineage, but it causes a reactive bone marrow fibrosis. And when that happens, the body then relies on extramedullary hemopoiesis. Okay, so where is extramedullary? Usually in the spleen. So patients that come to us, often they come with a huge spleen, massive spleen. Okay, the spleen is here in your upper quadrant. It can extend all the way past your umbilicus, sometimes even extending into your right iliac fossa. Left upper quadrant, right iliac fossa. Okay, so it can be that huge. So the mutation again is caused by JAK2. It causes a hyperplasia of your abnormal megakaryocytes, but these megakaryocytes secrete a type of growth factor that stimulates proliferation of fibroblasts. So when it does that, the fibroblast proliferates and causes fibrosis. Okay? You can have other causes of myelofibrosis. So in primary myelofibrosis, it's a mutation, but in secondary myelofibrosis, other things induces the myelofibrosis. So um, interestingly enough, patients with very long-standing polycythemia vera and ET can subsequently turn into myelofibrosis. As you can imagine, if the marrow is so overworked in such a long time, lama-lama it will ultimately break down, right? So the breakdown that occurs is myelofibrosis. So there is a phenomenon called post-PV myelofibrosis or post-ET myelofibrosis. Okay? And then other hematological disorders can also cause acute myelofibrosis, like other leukemias. Chronic myeloid leukemia can also cause myelofibrosis. So anything that is proliferating in the bone marrow can induce um, myelofibrosis. Okay, it's not common, but it can happen. It does occur, and then non-hematological disorders can also cause myelofibrosis. Okay, so that's why we it's called primary myelofibrosis to differentiate it from all the other secondary causes. So the clinical features is insidious onset. Okay, insidious because the term insidious means very slow growing lah, very slow but sinister. Okay, that's the what insidious means to me lah. And then you present with massive splenomegaly because by the time that the patient comes to you, they don't really they don't really have other symptoms, right? Except they come to you and say, oh, recently I've been starting to feel really full. Macam nak makan cepat kenyang and I rasa sangat bloated. I feel like my tummy is bigger than usual, and then when you palpate, actually the spleen is massive. Okay? And then if it reaches the point of myelofibrosis, patient will have symptoms of anemia, symptoms of hypermetabolism, and bleeding. Okay. So the FBC in the early stages can have leukocytosis and thrombocytosis, but when the myelofibrosis kicks in, it will be pancytopenic. Okay. The blood film is a typical finding of myelofibrosis, right? And in the typical finding is that it has leukoerythroblastic picture with presence of teardrop cells. Okay, so if I in the lab get a case and the MO writes the patient presents with anemia, HB of 8, white cell count of 2, right? And on examination, massive splenomegaly. Okay, and then I look at the full blood picture under the microscope and I see teardrop cells and I see a leukoerythroblastic picture, then I'm 90% certain that this patient has primary myelofibrosis. Okay, because that description, the blood film description, is so very typical of primary myelofibrosis. Okay. Do you know what leukoerythroblastic picture means? Have you heard the term before? Has it been introduced to you? No? No. Okay, so leukoerythroblastic picture is when we see on the FBP nucleated red blood cells and presence of left shifted granulocytes. So when I say left shifted, means not the neutrophils, but more immature forms like myelocytes, promyelocytes, metamyelocytes, and blasts. Okay, so that's why it's called leukoerythro, white cell, red cell, blastic picture. You see immature forms in the peripheral blood because you're not supposed to see the immature forms, right? I told you, dia nak kena jadi doktor dulu baru boleh keluar, right? Tapi ni medical student dah keluar dah in the peripheral blood. Okay, so typically what we see is myelocytes and nucleated red cells. Typical. Kadang-kadang, jarang-jarang, I will see metamyelocytes, promyelocytes and blasts. Usually it's myelocytes and nucleated red cells. And the moment I see that, I can use the term leukoerythroblastic picture already. Okay? And coupled with that is teardrop cells. Has Dr. Prof. Fazila show you the different types of abnormal red cells? Ada tak? Kan? So like in IDA, you get pencil cells. In thalassemia, you get target cells. Right? In hemolytic anemia, you get schistocytes. Right? So those are the different types of abnormal red cells. So here in myelofibrosis, the abnormal red cells is called teardrop cells. And why is it called teardrop cells? Because it looks like a teardrop. Okay. The bone marrow initially is very hypercellular. Again, a lot of megakaryocytes. So sometimes they can look almost similar to essential thrombocythemia. Okay, but usually it also is accompanied by a granulocytic hyperplasia, whereas in essential thrombocythemia it's only a proliferation of the megakaryocytes. Okay? So PV is panmyelosis, all 3 cell lines. Myelofibrosis is usually we see proliferation of granulocytes and megakaryocytes in the initial phase. Ultimately they become fibrotic, okay? They become hypocellular. And then in ET, you only see megakaryocyte proliferation. You don't see erythroid or granulocyte proliferation. Okay? Then, when it becomes fibrotic, typically, it's very hard to aspirate the bone marrow. So how do we do a bone marrow examination? Is we take a huge needle with a large bore, a large diameter, okay? And we stick it into your posterior superior iliac spine, and we drill it, and we aspirate the sum-sum tulang. We aspirate the marrow, okay? We then put it on a slide and we smear it. So that's how we do a bone marrow aspirate, okay? But if the marrow is full of fibrosis, it won't be easy to aspirate. Okay? It will get stuck. So that term is called a dry tap. No matter how many times you try to draw the marrow out, it just doesn't come out. Okay? So that term is called a dry tap. Again, mutation studies will be JAK2, CALR, and PL. And it has more of a hypermetabolism effect. So it has high LDH and high uric acid. That just basically means that in myelofibrosis there's a higher cell turnover. Okay? Okay. So this is what I mean by leukoerythroblastic picture. You see a nucleated red cell, and here you see a blast, or like I said, a myelocyte or a metamyelocyte or a promyelocyte. Okay, so this just seeing 2 of these is enough for me to say it's a leukoerythroblastic picture. And these are poikilocytes or teardrop cells because they literally look like the shape of teardrops. Okay. So this is a typical myelofibrosis picture. Okay. So the bone marrow biopsies, like I said, in the initial phase, the pre-fibrotic phase, before the fibrosis sets in, you have a granulocytic and megakaryocytic proliferation. And the megakaryocytes are mature but atypical, not that typical. And the fibrosis hasn't set in yet. But once the fibrosis has set in, Dr. kata dry tap kan susah nak aspirate, so it's difficult to see. But what you see here is a trephine biopsy. Okay. So when we do a ujian sum-sum tulang, not only do we take a aspirate, not only do we draw out, what we do is then we put in a biopsy needle. What is a biopsy needle? It's kind of like a gunting, right? Where you go inside and you cut a piece. Okay? So this is bukan aspirate kan? Because you not draw out. Ni gunting, you potong. So you potong a rectangular shape, and once you dah potong, senanglah nak keluar. Betul? Kan? So when you see it like this, where you can see the cells, you can see the bone, this is a trephined biopsy. Okay, this is when we cut out a piece of the marrow. We literally take out the bone and the marrow, the sum-sum tulang, and we put it on a slide. Whereas this one, tak ada. Sorry, I didn't show you an aspirate. Tak apa, nanti masa practical, I will make sure to show you, okay? Okay, so the pictures that I've shown you here are all trephined. So in the initial phase, it will look like this, highly proliferative, lots and lots of cells, because in an adult, right, you may think macam, okay, so what? It's like, doesn't look abnormal pun. Like, what is abnormal, right? You probably have no idea what abnormal looks like. But in an adult, the bone marrow should consist of cells and fat cells. Okay? It should have blobs of fat species. Okay? But typically in myeloproliferative neoplasms, it doesn't have those fat cells because it's very, very hypercellular. So those fat cells are displaced. Okay? There's no space for them anymore. Okay? The opposite is aplastic anemia lah, where instead of cells, all you see is fat species. So that is the other end of the spectrum. Okay, in aplastic anemia, dah tak ada dah hemopoietic elements, all you see is fat species. And in myeloproliferative neoplasms is the opposite. You see lots and lots and lots of cells, and you hardly see any fat species. Okay, and in the fibrotic phase, these black fibers here, these are those reticulin fibers. Reticulin is a type of collagen that is made by the fibroblasts. Okay? So these will become lots increased and it will become very thick. You will see thick bundles of these reticulin fibers. Okay. So how do we treat it? Because like I said, patients usually present to us with splenomegaly, so we try to reduce the size of the splenomegaly. And how do we do that? Is by reducing the number of cells. So again, reducing effects of splenomegaly is trying to cut down the number of cells by using hydroxyurea. And then ultimately, some patients, we just remove the spleen because it's so uncomfortable for them, it causes so much problem for them that we just remove the spleen. Okay? This is my last slide. Okay, so like I said, there are the three main ones. Red cell precursors becomes polycythemia vera. Megakaryocytes becomes essential thrombocythemia. But again, megakaryocyte proliferation leads to reactive fibrosis and can cause primary myelofibrosis. Betul? But I also said that with very, very long-standing PV and ET, it can also lead to primary myelofibrosis. So that's the arrow down there. 30% of PV becomes post-ET MF. 10 to 20% becomes of ET becomes post-ET MF. Okay, but interestingly enough, all of these can also transform into acute leukemia. Okay, it can transform into acute myeloid leukemia, of course, because they are of myeloid origin. Tak masuk akal lah kalau you have proliferation of myeloid cells and then suddenly you have acute lymphoblastic leukemia, right? That said, ada je. Okay, nothing is ever 100% in medicine. So I have seen cases where instead of a AML, acute myeloid leukemia, they then present with an acute lymphoblastic leukemia, but it's very, 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 very rare. Okay, that's it. Any questions?